Thank you for this kind invitation to be here today and share this very contemporary, very important topic that has been introduced by Asim. So we are now in an era where, in fact, we have very effective options, but we're still learning how best to use them. This is where I work. This is in North Carolina, the Norin Cancer Institute, that actually has multiple sites all over Carolina. Somebody was asking me where I work, Keller. So this is where I work, and this is the map around that area. So we're not too far away from the mountains or the water. So there are 11 sites for the center. Dr. Golak asked me to kind of present a short timeline of immunotherapy because I understand they're basic science people here, they're clinicians from various disciplines. So just to kind of go back to the 1700s, 1800s, Paul Ehrlich had looked at the side chain theory and had felt that there were proteins that got modified when the body was faced with particular insults. Virchow had looked at tumors at that point and seen cellular infiltrates in these tumors. And then there was the surgeon in New York, and like rheumatologists do what they do, surgeons do what they do. So Coley noticed that causing inflammation could result in resolution of tumors. So he got hold of a bunch of different bacteria extracts and mixed them up and started injecting them. That was called Coley's toxin. And Coley's toxin actually induced inflammation in a lot of people. He had a response rate of about 15% in sarcomas, but a lot of people also died. So that didn't really catch. Macfarlane Burnett was probably the biggest influence in developing immunotherapy. He was against immunotherapy initially. He felt our body's own immune system would not attack self cells, and cancer cells are self cells. He changed his mind in 1960s and decided no, there were antigens that were different on tumor cells and they could be recognized and these cells rejected. Interferon was the first drug to be approved for immunotherapy in melanomas and in hairy cell leukemias and a bunch of others. Interleukin-2 came in 1992, was approved for renal cell carcinoma, and then subsequently in 1998 for melanoma. Adoptive cell therapy came in about the same time. Steve Rosenberg, working at the NIH NCI branch, started using tumor infiltrating lymphocytes to see if they could actually reject tumors. BCG was the next approval, non-specific immune modulation, bladder cancer. Ralph Steinman then described the dendritic cells. He did get the Nobel Prize. We're in the city close to Nobel. And unfortunately, it was posthumous because he died the day before the announcement was made. So, of pancreatic cancer that he was treating with his dendritic cells. Sipuleucel T was approved as a vaccine niche therapy for prostate cancer. So these are dendritic cells that are loaded with prostatic acid phosphatase and administered into the lymph node basins. And we'll talk a little bit more about ipilimumab, pembrolizumab, and nivolumab. These are the immune checkpoint modulators and how they work. And these are the contemporary agents that are extremely powerful tools, but they're also at times are difficult to manage. So here's a cartoon that I made of how the immune response proceeds. So here's a tumor cell up here on the left. These yellow blobs are tumor-specific antigens. Now, there are some tumor cells that will die spontaneously. When they die, they release these antigens into the system. And these antigens are now taken up by the antigen-presenting cells or the dendritic cells. They're processed inside the antigen-presenting cell, and they are re-expressed on their surface in combination with the self-MHC or HLA molecules. It is this combination right here that then becomes visible to the effector cells of the immune system. These are the T helper cells and the T cytotoxic or T killer cells. So here's a T killer cell that recognizes this yellow blob being presented by the HLA molecule, and that constitutes the first step in immune response against the tumor. The second step is activation of this T cell, and that happens via a linkage that develops between CD28, an accelerator expressed on the surface of T cells, with a family of molecules called B7 expressed on antigen-presenting cells. So this interaction now, B7 and CD28, activates the T cell. And that is what we need initially in an immune response. We need activation. Now, when it gets to a certain point of activation, a control molecule or an inhibitory or a braking molecule called CTLA4, CTLA4 stands for cytotoxic T lymphocyte antigen 4, that gets expressed on the surface of that activated T cell and interacts with the same B7 family of molecules. That interaction is inhibitory and switches the T cell off. So these are events happening in the lymph nodes. These are central immune system events. And that results in the T cell being switched off. Now we can bring in the anti-CTLA4 antibody that Jim Allison's lab had been working on and showed that blockade of the CTLA4 molecule results in the T cell being prevented from switching off. So now this T cell is activated. There's no break on this T cell, and that's what we think goes and results in anti-tumor effect. So that is this is just a cartoon, animated cartoon of the same, where this is the dendritic cell presenting the antigen to the activated T cell. Activation happens through CD28 and B7, and then the CTLA4 comes in. CTLA4 has more avidity for the B7, and that results in the T cell being inhibited. Anti-CTLA4 prevents, or ipilimumab, there's another antibody called tremelimumab, it prevents the T cell from being switched off. And we know that it is now been looked at in various disease processes. It is already approved for malignant melanoma. Tremelimumab is being actively looked in multiple disease sites. So I'm basically a melanoma and renal cell doc. This is the old style kind of immunotherapy kind of people. So most of my data that I'll present will come from melanoma and renal cell patients. People who were treated with ipilimumab, about 20% of them are now alive 10 years out, and there appears to be a plateau that hits, that the survival curve hits. So this is for those folks who are basic science people in the audience. This is time in months. This is survival. This red blob is the 36-month mark, and once folks hit the 36 months mark post-treatment with ipilimumab, they don't appear to then fall off that curve. So 20% of them are alive 10 years out. Remember, the median survival for stage 4 melanoma used to be 6 to 9 months. So now we saw improvement out there. And these responses can be fairly remarkable. This is a patient who was treated and was one of the earlier IPI studies. for those again who don't look at scans all the time, this is somebody who's lying on the table down here, feet are towards you, and this is a cross section at the level of the liver, and this is the spleen out here. This is the spine. So the liver, this is not normal liver. All of those dark spots are actually melanomas. And this was a young patient, 40-something-year-old, was eligible for the study. We put him on the study, and as of 2016, the liver is completely normal. There are areas of calcification that indicate treated disease. So these responses can be quite impressive and durable. Earlier on, this melanoma patient would not have survived. Now, moving from the central immune events, where the tumor presented the antigen, the tumor shed the antigen, and the antigen was presented by the antigen-presenting cells to the T cell. Now we move into the tumor microenvironment. These activated T cells, when they get into the tumor microenvironment, they have to counter a lot of immune suppression there with T regulatory cells, with myeloid-derived suppressor cells, and with a molecule called PD-1 that is another off switch or an immune checkpoint expressed on the T cells that has two ligands, PD-L1 and PD-L2, that when interacts with the PD-1 results in the T cell being switched off. So there was one off switch with CTLA4 at the central immune, in the central immune events, and now in the tumor microenvironment there are yet other off switches that can come on and switch the T cell off. So the tumor has its own escape mechanism in some ways. So we can now bring in the anti-PD-1 antibody that can block that interaction between the PD-1, the programmed death one protein on or switch point, immune checkpoint on T cells, and the tumor cells, and results in the T cells remaining active and killing the tumor cells. So this is a tumor microenvironment effect, central and peripheral. And this can also be done by inhibiting the PD-L1 on the other side of the equation. So essentially the PD-1 axis needs to be inhibited, either the PD-1 or the PD-L1 inhibitor. And both these drugs are being looked at and now approved. So here's the cartoon for that. Here's the PD-1. Here's an activated T cell coming to kill the tumor cell. PD-L1, PD-L2 results in switching the T cell off, and then using either a PD-L1 antibody or a PD-1 antibody, we can prevent that T cell from switching off, and that is how we think that works. And the PD-1 inhibition has gone all over, it's exploded. It's not only going to be the melanoma renal cell guys, it's going to be almost everybody. I think it's going to be added to the water supply at some point. So here's the various PD-1 inhibitors. Nivo and Pembro have been approved, Atezo has been approved, Velimab has been approved, and there are several others in process. The ones in the disease process marked in red are all where already there are approvals and indications. Others are being looked at. So this was the initial phase 1 study that Suzanne Topalian presented with nivolumab. And it was it had five different disease sites with 5 different doses of nivolumab or PD-1 inhibition. And I'm just showing this as a representative because there is PD-1 inhibition with Pembro, and all of them, both PD-1 inhibitors look similar. This was the amount of tumor change noted. Each of these bars is a patient. This 0 line is the baseline, and this dotted line below that, minus 30%, is what would constitute response by RECIST criteria. 20% increase would be progression of disease. And you can see with PD-1 monotherapy, there were a significant number of responses noted in melanoma. And these responses at times are pretty impressive. This is a CT scan at the level of the hip joints. So it's the right hip joint, left hip joint. Again, this person is lying on the table, feet towards you. This was a large mass sticking out the right lower abdomen, and this is post-treatment with Nivo. So really very, very impressive responses. Earlier on in melanoma, we never saw these kind of responses. And now what we know about PD-1 inhibition is recently Steve Hodey updated that data from the initial phase 1 study. So at 5 years, 34% of the folks who were treated with monotherapy with PD-1 inhibition are alive and doing well. And there appears to be, for PD-1, there appears to be a 48-month kind of plateau starting about 48 months. So about 4 years in, we saw with IPI, or the CTLA-4 inhibition, at 3 years, this curve plateaued out. For the PD-1 inhibition, it appears to be about 4 years. And this is data for pembrolizumab, similar data. Just wanted to make sure that I'm not looked as being biased for one PD-1. So both PD-1s do the same in melanoma. Now we had the central immune events. We have the tumor microenvironment events. So can we block both? We block the CTLA-4 molecule so that centrally the T cells that are being stimulated do not get switched off, and then we also prevent their switching off in the tumor microenvironment. And that data was very impressive. This was the phase 1 study Jed Wolchak reported. Again, the same waterfall plot where each bar is a patient. And these are advanced melanoma patients where we never ever saw these deep responses with 80% decrease in tumor burden. So when the bar goes below the 0, that signifies response or decrease in tumor burden. And so 100% would be a complete response, and this line down here is more than 70% response. So 70% or more decrease in tumor size was never ever reported. This data was updated by Mario Schnall last year. So at 36 months now, 70% of the people are alive. Remember, this was a disease process where 6 to 9 months was the median survival. So the curve used to be somewhere here. And now 70% of the folks with advanced melanoma are out 3 years. So impressive indeed. And this is just to kind of show you in one picture what all the different options of melanoma are right now. This black curve down here is chemotherapy. So compare that to where we are now with dual immunotherapy. So very, very impressive outcomes and interesting times for the melanoma docs. Now, where does the toxicity come in? We saw a rheumatology case earlier on, and here's a simplistic way of how I describe toxicities to our patients, because it is extremely important that they understand what is going on. If they do not report to you, no matter what the toxicity, if you're not able to respond to these toxicities appropriately and in a timely fashion, that is when the wheels can come off, and sometimes you can't put the wheels back on that bus, and deaths can happen. So here's what I tell them. I tell them, your immune system has a cruising speed of about 65. And then the immune system decides it has to bump up the speed, and the normal immune response goes up and gets to 120. And then the auto mechanisms, the brakes or the cruise control, the CTLA-4s and all, they hit. And now the speed kind of comes back down. And that is where we bring in immunotherapy, so we can break the brakes, and we want to go 160. That's what our goal is. The problem happens when the immune system starts going 240. And that is when we see normal organ damage. So what organs can be damaged? Any organ can be damaged. These are the ones that are most commonly seen. So I'm going to use, how much time do we have? I have plenty of time, okay. So I'm going to just use some clinical scenarios to illustrate what all has been observed. And I know Dr. Keller is going to be discussing some of the management of these toxicities later on. All right, so the most common is skin manifestations. The dermatitis, autoimmune dermatitis. So this is a gentleman who presented post-treatment with CTLA-4 inhibition with a rash, usual rashes, grade 1, you don't even have to do anything about those, managed with topical stuff. Higher grade rashes need to be treated with steroids and all. Because in the early studies, there were actual deaths with high grade dermatologic toxicity in the form of Stevens-Johnson's and toxic epidermal necrolysis. So, but most of the time you don't have to do anything. Just treat them with steroids, they're okay. Sometimes they can be impressive rashes. Sometimes you need more steroids and longer period of time for steroids. Here is somebody who got only 2 doses of pembrolizumab. Now that is thought to be, PD-1 monotherapy is thought to be extremely safe, much safer and easier to do than IPI, but not always. So, be cognizant that PD-1 inhibition is powerful. Continuing with the skin manifestations, this is actually an African American gentleman who was treated with PD-1 inhibition and developed vitiligo. Vitiligo is considered a good correlate for outcomes in melanoma. So, but look at the skin, how impressive the vitiligo has been. This is supposed to be an anti-melanocyte response. So when it takes the bad melanocytes or the melanoma cells, it can also take the normal melanocytes. And for him, look at this finger that he presented with. Don't mean to gross you out, the basic science people. I apologize, but I had to show you some clinical scenarios. But look at that finger now. So impressive kind of both toxicities and outcomes. Autoimmune colitis is probably the most dreaded and in some ways important toxicity. This is a gentleman who had presented with advanced melanoma, and in those early days the clinical trials would have maintenance therapy built in. So he was on maintenance therapy with CTLA-4 inhibition. Week 108 or something like that, about a year and a half, 2 years into the maintenance, he presented with diarrhea and also had changes in his vision. So he was diagnosed to have autoimmune uveitis, that is inflammation of the posterior chamber of the eye, and also had scope done that showed, and sometimes you can see these whitish kind of deposits on colonoscopy. This is, if you biopsy these whitish chalky deposits, all you see in there are lymphocytes. So these that's one manifestation. You can see erythema or redness of the colon out here, and you can see actual ulcers developing. People can slough off their colons. So if it is not treated appropriately and early, they can get into trouble. These are the scans for this guy. This is a scan at the level of the neck. So again, this person is lying on the table, feet towards you. This is the air pipe in the neck. This is the left collarbone, and you can see a large lymph node sitting on the left side of the trachea, and that is gone and has been gone. These are scans 8 years out now. This is a liver lesion sitting right here, next to the gallbladder. That liver lesion is all gone, and he remains in a complete response. So again, very powerful agents, but can have life-threatening toxicities or organ damage. So this is from a patient who probably had underlying Crohn's disease, never was diagnosed, had an inflammatory bowel condition, got only 2 doses of immunotherapy, and then went into very, very brisk colitis. We did take them, and I'm sure Dr. Kerr is going to mention, we did take this patient to infliximab, which is now probably a standard that is being employed earlier on in the management of colitis. Despite infliximab, a couple of doses, the patient was ready to perforate and went on to colectomy. She is also in a complete response from her melanoma. So she's so sometimes we unmask autoimmune processes that may have been subclinical. That, as was mentioned, especially with rheumatologic issues, sometimes they may not have manifested yet, but when we do our treatment, we tip the balance over and they go into a florid kind of clinical syndrome. So this is just a reminder that early intervention needs to happen. Now, autoimmune hepatitis or liver damage has been noted. And these are the graphs for 2 of the liver enzymes called ALT and AST. So this patient presented after 3 doses of treatment, and the only manifestation he had clinically was, he was not jaundiced or anything, the only manifestation was that he said he didn't feel too great. I said, what do you mean? And he says, well, I normally skydive, but I just didn't feel like skydiving. So I said, okay, fine, So we looked at his labs before his 4th dose, and his AST and ALT had bumped up into the thousands. We treated him with high-dose steroids, and his enzymes did come down, but then went back up, and that is when we had to use higher level of immune suppression with mycophenolate mofetil. If you look at the data out here, this is January 2006. As of right now, this gentleman also is in a complete response. 3 doses of treatment total. Somebody was talking about hypophysitis, and this is a patient who I remember very distinctly because it was 24th of December, and I spent that evening with her in the emergency room. This is a pre-treatment scan, so now the scan you're looking at is somebody from the left side, so this is a cross-section of the brain, and this is the nose, and this is the brain. This is where the pituitary gland is, and she had presented with severe headache that was located right in the center of the head behind the eyes. I don't know what happens, how things work in the emergency room in Norway, but in the US, if somebody presents with severe headache, the emergency room physicians will do the most useless test possible, and that is a CT scan of the head without contrast. Well, it does rule out a bleed, but it doesn't really do anything else. So I had to go to the ER, convince the ER doc, look, you have to get an MRI. So we got the MRI, and what we saw was compared to the pre-treatment scan, now the pituitary gland had swollen and was really inflamed. Was treated with steroids, and this is the post-steroid scan. And I'm sure this discussion is going to come up later on. Most of these folks will end up requiring replacement forever. Thyroid abnormalities are seen. This is hyperthyroidism is probably the very first thing that we see, and that can happen very rapidly within the first 4 to 6 weeks. And this is a patient who started on treatment here. rapidly went up. As the free T4 or thyroxine level went up, the TSH went down. And then usually what happens is you don't actually have to treat them unless they're symptomatic, but usually these thyroids will burn out. So over a course of 8 to 12 weeks, the thyroid, so it's almost like the condition called Hashimoto's thyroiditis. That's an autoimmune thyroiditis, but here we're doing it to them. So the thyroid then burns out and they end up getting replacement for their thyroids. More recently, what has been seen is that, especially with the PD-1 inhibitors, there's been onset of new diabetes, and this is not type 2 diabetes or just hyperglycemia. This is actually type 1 diabetes. So the pancreatic cells also express PD-L1, and that maybe nature put that PD-L1 there to prevent the T cells from coming out and taking out the pancreas. And now we block that PD-L1 inhibition, so the T cells go and take out the pancreas. So these guys present with type 1 diabetes in diabetic comas or diabetic ketoacidosis. This is a patient who you can see. This is, I just put the glucose levels and the pH indicating that both times when he was, even with moderately high blood sugars, actually had acidosis. Pulmonary toxicity has been seen. This is a non-infectious pneumonitis. And so here's a CT scan of this patient. He was actually treated on the 067 study that Wolchuk reported a couple of years back. So here's the patient lying on the table, feet towards you. There's a cross section of the right lung, left lung, and here's the trachea. The lungs look normal here. Patient's wife called. The patient didn't call. Patient's wife called and said, he was mowing the yard, and then I see him lying in the grass, huffing and puffing. We talked to the patient. Patient said, "Oh no, I'm okay." He said, "We bring him in, got a CT scan done, and look at all this inflammation in the lungs." He was treated with steroids, complete resolution, and continued on PD-1 inhibition. So lower grade toxicities you can treat with immune suppression for brief periods of time, and they can continue. High grade toxicities other than endocrine toxicities should not be continued any further. Sometimes we don't see complete resolution of toxicities. This is a patient who had this large lymph node sitting here, and this is the baseline, got treated with 2 or 3 doses of PD-1 inhibition, and developed all this pneumonitis. He was clearly symptomatic of dyspnea, requiring oxygen. He treated with steroids. He still remains on steroids at this point. So this is just to show, going to your area of interest. This is a PET scan from a patient who had ocular melanoma. Ocular melanomas used to have response rate of 0, and also had very poor survival. 6 months was long for them. This is the liver that had a large lesion before. That was treated with embolization. He developed more disease and was treated with PD-1 inhibition, and he cleared out that completely. But he came next time in a wheelchair, and these are the PET images from the knee joints above. So this is only 3 months apart. Look at the effusions and how warm these effusions are. There's the ankles. So he was wheelchair bound at that point. We did need to take this person to high-dose steroids and infliximab to get him back to ambulation. We've seen neurologic manifestations. This is a gentleman who presented with ptosis on the right side. We couldn't figure out initially, we didn't think about it because we normally don't see myasthenia, but he did actually have myasthenia. He had antibodies that were positive, was treated with pyridostigmine, and to date continues on treatment with a major response in his liver. So that's his liver before, that's his liver now. If this was 2000, year 2000, October 2000, with that liver, we did not have anything for an 87-year-old person. This guy's 87, being treated with PD-1 inhibition and is doing well. So this is, now more recently what has been described as myositis and myocarditis. This is a patient who was treated and had chest discomfort, came in to the emergency room. The troponin level, that's an initial test to rule out cardiac damage, did show a bump in the troponin indicative of myocardial damage. We checked we checked the CPK levels, that is an indication of muscle breakdown, and that was also very high, over 1,000, was treated with steroids and did improve. But these conditions, myositis and myocarditis, can be fatal. This is just to show you the uveitis that can happen, and that appropriate management will reverse things almost 100% of the time. So I think that was probably my last slide. And this is just to kind of show you that this is the tip of the iceberg that we're looking at right now, because all we're looking at right now is the CTLA4 and the PD-1 checkpoints. There are numerous others that are actually being looked at. The TIM3 lag, 4-1BB, OX40 ligand, and OX40 antibodies, they're all being looked at in clinical trials at this point. So this is only going to require more effort to control the toxicities than less. So I just thought I'd throw that in. And rewards with the immunotherapy can be substantial, as you can see, but it is important to know when to apply brakes, because if brakes are applied appropriately in these individuals, we can reverse the toxicities almost 100% of the time. The problem is that at times the patients will not report because they think we will discontinue their treatment, or at times it is not recognized that this is an autoimmune toxicity, and that is when crashes happen. I thank you for your attention, and if there are questions.